this is a pharma symposium and sponsored by AstraZeneca. It's important to note here that it was a last-minute invitation for various reasons, and also it's important to note that we treat all biologics the same way. We don't favor any biologics over the other, and the data that's going to be presented here will be what's been published. So as I said, we don't favor any biologic over the other. So this is the disclaimer. So I'm going to start with giving you a bit of a brief introduction about the asthma, which I think at this stage you've known all things that needs to be done about it. But if we go back to the definitions of severe asthma, and I think Ashraf Zahabi had spoken at length about the definitions as GINA guidelines published it. So it's, as we know now, that severe asthma is that asthma that is not controlled despite maximum optimized therapy after treating the comorbidities, or that asthma that worsens when high dose treatment is reduced. And so what is what's the proportion of adults with difficult to treat asthma have actually severe asthma? And this is again a Dutch study that was published a while back. And if you look at this study carefully, you find that around 4% of those that difficult to treat asthmatics do have actually severe asthma. And this is, we're talking about GINA step 4 and 5, plus poor symptom control with good adherence to medications and good inhaler technique. So we're talking about a small number of patients. However, as has been said before, I think we're talking about 10% of difficult to treat asthmatics with severe asthma. So this study was published last year, and it was a collaboration between Professor Bassam Mahboub, Professor Zahabi, and us in Cleveland Clinic. And this is the sort of the largest study in the Middle East looking at patients with severe asthma. Basically, it's a demographic and clinical patterns, and we looked at different parameters. But the important thing to note here that, like that, what has been shown before, that type 2 asthma is really the predominant type in severe asthma, and that concurred with our finding. And in that, about 76% of our patients had type 2 asthma compared to the non-Th2 asthma. Okay, so central to type 2 inflammation are the eosinophils. So the eosinophils are really very, very important cells in type 2 inflammation. More so, they're the predominant cell type in Th2 high asthma. Now, these cells are stimulated by the, I'm not going to bore you with a lot of immunology, but it's important to know that these cells are stimulated by different factors, including environmental, but most importantly, they are stimulated by the innate and the adaptive immune system. Once these cells are stimulated, then they produce more than 20 mediators that cause the common symptoms of asthma that you see, like increased mucus production, airway hyperresponsiveness, tissue damage, airway smooth muscle constriction, and airway remodeling, etc., etc. Now, the most important factor for the differentiation of eosinophils is IL-5. This is the most potent activator, actually, for eosinophils. And it is produced by several cells of the immune system. And once IL-5 is produced, it helps differentiation of and maturation of eosinophils, helps cell migration to sites of inflammation, release lots of mediators, and inhibition of apoptosis. And again, how do we know that? Did we know that the IL-5 is important? this is done through, and this is done quite actually far back, about 30 years ago or so. Studies have shown that if you block the IL-5 receptor, you got inhibition and reduced differentiation of eosinophils. Now, back to severe asthma, and it has been shown that blood eosinophils have actually correlated more with exacerbation risks, more so than total IgE. And not only that, but if you look at patients who relapsed on mepolizumab, which is the anti-IL-5, you find that about 50% of who exacerbated their eosinophil counts were significantly high. So it means that the eosinophils and their presence is really an important factor in asthma exacerbation, particularly in patients with severe disease. Now, if you go back and look at the International Severe Asthma Registry, this is the largest UK-based registry for severe asthma. Again, it shows that about 84% of asthmatics have the eosinophilic phenotype. How do we recognize these patients? Easy and simple if you think about it. So they have certain characteristics. Of course, they have elevated blood eosinophils. They're frequent exacerbators, and they would have lots of upper respiratory disease, including chronic rhinosinusitis with or without nasal polyps. They are your patients who you need to give frequent courses of oral corticosteroids. And it is a late onset, so patients who present later in life with severe asthma, they're likely to be eosinophilic asthmatics. And of course, low FEV1, often with persistent airflow limitation, is quite common. Now, the other important factor, which is not mentioned in this slide, is that a lot of these patients would have negative allergy testing, or most of them, although they might have a raised total IgE. So the total IgE could be raised in these patients, but if you do specific allergy testing, it's usually negative. Now, understanding the mechanism of action of IL-5 and the importance of eosinophils in asthma pathogenesis, of course, pharma jumped on the idea, and several years ago, they produced factors or monoclonal antibodies that target the IL-5 itself. So we have mepolizumab in the market, and mepolizumab actually binds to IL-5, preventing it, preventing IL-5 binding to the S receptor in eosinophils, and that causes passive eosinophil apoptosis and not total depletion of these cells. While the benralizumab, which is an anti-IL-5 receptor alpha antagonist, actually binds to the receptor itself and actually induces what we call apoptosis or antibody dependent cell-mediated cytotoxicity through the NK cells or natural killer cells. So basically, it depletes all eosinophils from the circulation as well as from the tissue. Now, the benra has been studied quite extensively over the years, and these are the key studies. The key studies evaluated efficacy, effectiveness, safety, and in severe eosinophilic asthma. And I learned only a few days ago from Lynn that these names, the Sirocco, the Kalima, and the Zonda, are names of the wind. And this is basically because the program for looking at benralizumab is called World Wind or Wind World program. So I always wondered how they come up with these interesting names. So it is, as I said, names of the wind. So as I said, it's been extensively studied throughout the years, and these are the key studies. And of course, one of the key elements that these studies have looked at is exacerbation rate on benralizumab. And as you can see here, the Sirocco and Kalima study, 1 year of treatment showed that about 63% of patients had no exacerbations. And this is interestingly, this is more evident after 2 years. So 2 years of treatment with benralizumab, actually, patient enjoyed exacerbation-free time. Now, the pooled data analysis showed that the exacerbation reduction was consistent across different comorbidities. So it doesn't matter whether patients have severe asthma on its own or with other comorbidities, including higher users of oral corticosteroids, nasal polyps, and high exacerbators. So it was consistent. The effect of it was consistent throughout the years, and with no without any issues, actually. So they looked at exacerbation does it matter if the patient is atopic or have levels of IG that are raised or low? And in fact, these studies like the pooled Sirocco and Kalima showed that exacerbation was consistently reduced regardless of the patient's atopic status or the IgE levels. Interestingly, when they did the Sirocco sub-analysis, they found that the higher the IgE, the better improvement in exacerbation reduction rates, which is really quite an interesting observation. Right. Okay, another important aspect when we treat our patients with biologics is safety. So again, safety with benralizumab have been studies on different studies as shown here, and no safety concerns were found and with the medication and with long-term depletion of eosinophils. And I would like to bring your attention to the Multime study here, where the study went up to 5 years, where we have no issues with benralizumab. Now, about 70%, now again, this is a long-term study over 5 years period, and this study showed that about 75% of patients treated with benralizumab had 0 exacerbation per year from the predecessor studies or from predecessor studies throughout the treatment and during the safety extension period. So in other words, over the 5 period that this medication was studied, the majority of patients had no exacerbations at all. Another element that we're looked at is OCS reduction and elimination with benralizumab. And again, just to remind you that even small doses of systemic corticosteroids can actually have a serious adverse effects, and this serious adverse effects would increase with higher cumulative steroids exposure. So in the benralizumab studies, OCS elimination was, in the Zonda study, for example, when they looked at the, the OCS elimination, they found that about half of the patients, slightly more than half of the patients, were able to actually eliminate the OCS completely. And this was shown also in the open label studies, and even the numbers were higher. So the percentage of patients reached up to 63% of those patients who eliminated the OCS while on benralizumab. And the interesting bit is that despite the fact that these patients were either eliminated or reduced their OCS, the exacerbation rate with up to 70% 0 exacerbation on treatment. So the patients had almost no exacerbations with reduced or eliminated doses of steroids. Now, benralizumab was also looked at in patients with severe asthma and nasal polyps. And again, This is the Andy study where they looked at this particular question. And again, the benralizumab had really an important effect on patients with severe eosinophilic asthma with nasal polyps, with almost 80% of patients reaching clinically meaningful improvement in SNOT-22, which is a measure for nasal assessment. And that is really quite an impressive number to get to. Okay, so we spoke about the the randomized controlled trials with benralizumab. What does real-world experience say? It doesn't really say anything different, and this is a study, the Zaloc study, where it has been shown that the benralizumab actually reduced asthma exacerbation by 85%, and the oral steroids from baseline, which is really quite an impressive reduction to note with this biologic. Now, the Zephyr study is again a study which is involved 518 severe asthmatics. They had no exacerbation at all in short or long-term use of benralizumab. So again, that the question of exacerbation has been addressed here, and nearly all patients on benralizumab didn't have any significant issue with the exacerbation. Again, the Zephyr study also showed that further exacerbation reduction was seen when you switch patients from mepolizumab, for example, or omalizumab to benralizumab. So if you have a patient who doesn't really respond to MEP or OMA, then you can switch to benralizumab, and there is evidence there from this study that they will do better. Now, this is a very, very interesting study, and this is my last study that I want to talk about here. This is real-world effectiveness of benralizumab in severe eosinophilic asthma, and it's the same. The two studies were published at the same time, basically back to back, in chest by the same group. This is by David Jackson and his colleagues in Guy's and St. Thomas's. Now, these two studies are not head-to-head studies, but what they did here was they looked at benralizumab, the effect of benralizumab in severe eosinophilic asthma in one group of patients, and they did the same in another group on mepolizumab. And they divided their patients into responders and super responders. The responders they defined here is that these patients who have had more than 50% reduction in exacerbation, more than 50% reduction in their OCS, while the super responders had 100% reduction in exacerbation and of all OCS. So again, interestingly, you see that with the benralizumab group, the super responders were 47% almost, while and these are patients just to reiterate that they've had no exacerbation and they're off all their OCS, while only 28% had the same effect on this group of patients. But again, they're not head-to-head. This is important to note, and I don't think we'll see head-to-head studies with these biologics in the near future anyway. So in summary, severe eosinophilic asthma is the dominant severe asthma phenotype. Eosinophils, as we've shown, are key effector cells and are dysregulated in this group of patients. Raised eosinophil counts have been associated with increased asthma severity, high risk of asthma exacerbation, poor asthma control, and poor lung function. We've seen now what have been shown in several publications that benralizumab induces active eosinophil apoptosis, produces rapid and sustained complete depletion of eosinophils in blood and target tissue without ill effect. There is no ill effect from actually wiping the eosinophils from the blood thus far. And it significantly reduces exacerbation, improving lung function, and reduces OCS versus placebo. And the clinical benefits were sustained for up to 5 years. And there are no safety concerns, at least after 5 years of exposure. And this is just if you have any adverse effect to report. And I thank you for your attention.